Est-ce que vous êtes toujours là? On this day in October, some 6,000 people from Bordeaux gathered on the banks of the Garonne River to take part in a race. The Pink Ribbon Fun Run is organized to promote breast cancer screening.
You have to get screened. Screening is really important if we want to keep our beautiful breasts for all women.
The figures are alarming. 1 woman in 8 will one day be diagnosed with this disease, the leading cause of death from cancer for women.
My mother, my grandmother, my aunt. There's a whole history, so of course one feels very concerned. If I hadn't had that mammogram, I almost certainly wouldn't be here today.
They are unanimous because the message is unequivocal. Detected early, breast cancer can be cured in 9 out of 10 cases. So even the mayor of Bordeaux, Alain Juppé, put on his pink T-shirt.
It's a great cause. Sometimes we're skeptical about the efficiency of public policy, but this really works.
But are they really running in the right direction? Over the past few years, doctors, researchers, and epidemiologists have been carrying out new studies that are raising questions about breast cancer screening programs. Their work is throwing the very definition of the word cancer into dispute and opening up the way for new research protocols.
The overall utility of mammography screening is quite negative. It's a harmful intervention because there are no benefits, but there are lots of harms.
A woman would be well advised not to undergo breast cancer screening. Medicine is made for people who are sick, not people who are well.
I wish no one ever used the term, saves lives, because the fact is we do not know that.
For a long time, I thought that breast screening was a good thing, until the day my mother's mammogram revealed some abnormalities. She was in good health, but found herself confronted with doctors and the fear of cancer. Our lives were turned upside down. So I tried to sort out truth from incertitude in the breast cancer screening discourse. And I followed the stories of 4 other women who were also caught up in this torment. In France, Monique has just received some worrying news. She needs to make a decision. Faced with the same dilemma over in Canada, Patricia made a radical choice. Miriam underwent the same a decade ago in England, and she regrets what happened to her. Meanwhile, in the north of France, in Allouan, Ghislaine is enjoying her grandchildren with the carefree attitude of a young retiree.
Would you like some coffee? Pass me your cup. Here, it's steered. Thank you, that's better. I'm not thinking of being sick. I'm still young, so I'm fine.
Ghislaine does not feel like she's sick, but since the age of 50, she has been regularly screened for breast cancer.
I do it because it's free and you have to take part. And I also go because I think that if there's something, at least you can do something quickly if you discover it. It's like giving yourself an extra chance. Okay, lift your arm. I'm going to take your breast from underneath. Stay like that.
It is also an unpleasant experience.
It doesn't feel very nice, but we don't compress it any more than we have to. There. Don't move. Stay like that.
The position is uncomfortable, but the nervous wait for the results is the worst part. In the room next door, radiologist Vincent Loisel is focused. Reading the mammograms of women who present no symptoms requires experience.
It's not always easy to spot. When you're looking for anomalies, you have to find a place where there's an abnormal white area in zones where they shouldn't be, such as here on the edge, or here, deep down, in what we call the prepectoral fat.
With screening has come a new range of classifications. ACR 1 and 2, nothing suspicious. ACR 3, anomalies such as this little white patch which need to be monitored. ACR 4 means a suspicion of cancer. ACR 5, there is no doubt over the diagnosis.
By comparison with the right-hand side, which is normal, on the left there is a large tumification. The aim of screening is not to find these abnormalities.
Because big tumors are scary, and for a good reason. For a long time, breast cancer was incurable. It was the first known cancer and is extremely recognizable as it eats away at the breast. The tumor develops like a crab. Indeed, this image gave the disease its name. For a long time, the only treatment was the removal of the breast, a mastectomy. In the 19th century, people began to believe that this operation was more effective with smaller tumors. The survival of the patient therefore depends on the stage at when they seek medical advice.
At least a third of those who die of cancer could be saved if they started treatments early enough.
After the Second World War, campaigns were launched to encourage women to seek medical advice as soon as they discovered the first symptoms. Cancer was an enemy that had to be beaten. And a new weapon was now part of the struggle: radiography, helping detect cancer even before a tumor could be felt. The idea then emerged of offering all women regular mammograms, however healthy they were. That would bring down mortality rates. And to prove it, a series of experiments was carried out in the 1970s. Hundreds of thousands of women were divided into two groups. The first group was invited to undergo a clinical examination and mammogram every year. The second group simply carried on with their lives. The experiment lasted 10 years, and at the end, they looked at incidences of breast cancer in the two groups and the number of deaths from breast cancer. In the group that did not undergo screening, there were 30% more deaths. A conclusion was reached. The experiments proved what people had suspected. Breast cancer screening through mammograms was a success. It became part of public health policy. All over the world, every 2 years, women aged between 50 and 74 with no apparent symptoms receive an invitation to undergo a free examination and mammogram at a state-certified medical facility. Some gynecologists even take it into their own hands to offer these checks to women from the age of 40.
Hello, I'm Dr. Loisel. Nice to meet you. First, I'd like to tell you that your results are normal. I did not find any anomalies.
In 93% of cases, mammograms and clinical examinations detect nothing suspicious.
There's nothing to worry about.
There's always a little apprehension, but you have to do it. If they find something, you can get it treated straight away.
Ghislaine's screening stops there. A few kilometers away in Carvin, northern France, Monique has been worried for the past 2 weeks since her last mammogram.
When I went there the last time, I felt reassured. I wasn't expecting to hear news like that.
ACR4. While there are no symptoms, her X-ray revealed certain anomalies.
When the radiologist told me I had some suspect calcification, my insides kind of turned to liquid. It was like a tidal wave inside me. I was trembling. I had to try to keep my calm and not burst into tears. Then the radiologist reassured me, saying I'd get treatment very quickly and everything was going to be okay. That gave me back some confidence, and I went home a little happier.
Monique has now become a patient. She has been given an appointment at the hospital in Lille for a biopsy to be carried out by radiologist Luc Sugnard.
Today what we're going to do is sit you down on a table behind us, and we'll set you up so that we can get a sample of those little calcified elements deep inside the breast. All those little dots are calcium. You can only see them with a mammogram. You can't feel them. You can't even see them with the naked eye. Right now, we don't know what they are. So our aim is to extract enough of them to find out if there are cancerous or precancerous cells there.
Okay, come and lie down on the table and place your breast through the hole.
Microcalcifications don't make a solid tumor, and to extract a sample, the radiologist has to perform a macrobiopsy with a very wide needle that will leave a bruise. A local anesthetic is essential.
Biopsies are not a banal procedure. It's an aggressive procedure, whatever the outcome. That hurts?
Some patients require a little more anesthetic.
Is your head spinning?
Can you see me?
Are you okay?
Hi, Monique, how are you?
Ça va? Coucou. Vous me voyez?
She's not doing well, poor thing.
Despite her fainting, they must carry on with the biopsy because that's the only way to obtain a diagnosis.
Comment ça se passe? Ça va?
Great. Don't worry, everything will be okay.
Monique's lesions, detected by chance during the screening, are only a first indication of a problem.
You don't die of cancer inside the breast. You die of the metastasis, or the cells that travel everywhere else, creating metastasis. The idea is to detect the smallest lesions with the hope that they never evolve, and that women don't have to undergo all those aggressive treatments they all fear, such as chemotherapy. Our aim is to detect cancer at an intramammary stage, when it's still contained in the breast. In Monique's case, we're at the best stage we could hope for. She can't sense it, we can't see it, and you can't feel it with your fingers. If she had waited to feel a lump, we would probably be at a later stage in her illness.
For Monique and her family, a long wait is just beginning. Despite shopping trips with her girlfriends and attempts at distraction,
This place should be covered by health insurance. Well, that's not a bad idea. I'll make a request.
the idea of being sick has gained the upper hand. The fear of cancer has brutally invaded her daily life.
I'm scared of death, of losing my wife. We're waiting for results of the biopsy. So the hardest thing is yet to come. We know people die of this. It's a big deal.
You never know where it's going to go. My sister had a cancer at a very advanced stage. So I really know this process, and that's what really frightens me. There's the physical degradation, the weight loss, hair loss, and all the medication protocol. It tires you out and destroys you from within.
The uncertainty continues for 2 weeks, the time it takes for the samples to be analyzed under a microscope in an anatomical pathology laboratory. Mathieu Hiver is a pathologist and a specialist who is little known to the general public.
We're the ones who make the cancer diagnosis. And I'm not saying this to show off. We diagnose by looking at the lesions under the microscope. And depending on how the cell looks, if they look good, they're benign cells. And if they look bad, they're malignant.
Not all biopsies from breast cancer screening turn out to be cancerous under the doctor's microscope.
Out of 100 biopsies, only 10 are real cancers or invasive cancers. They're easy to diagnose. And then we'll find 10 precancerous lesions.
Precancerous lesions? Here the pathologist comes up against a problem to do with terminology.
With colon cancer, we call them adenomas.
That's a reassuring word for a benign tumor.
With breast cancer, precancerous lesions are called carcinoma in situ. The word carcinoma in situ naturally worries both patients and doctors, who then think it's cancer, but it's not cancer. It's a precancerous lesion that brings an increased risk of cancer, but it won't necessarily become cancer. And this is still very confusing for both doctors and patients.
Today we treat these cancer risks like full-fledged cancers.
If you say it's benign, the patient goes home. If you say it's carcinoma, carcinoma in situ, they risk having to undergo surgery. It's something I think about and it makes me uncomfortable. I'm uncomfortable about screening and I'd like it to stop.
Mathieu Hiver is one of the only pathologists to share his doubts. Within the framework of breast cancer screening, the diagnosis is based on an ambiguous definition of the disease. Yet calling precancerous lesions cancer has immediate consequences for women. Despite being in good health, they are classified as sick, and their world becomes one of hospitals, medication, and aggressive therapies. 60% of cancer patients experience a loss of revenue and stop working. Obtaining loan insurance becomes an uphill battle. This anxiety lasts for a long time. 25% of patients become depressed. Two weeks have passed, and Monique returns to the hospital to get the results from her biopsy.
I've got the results, and cancerous cells have been detected. It's breast cancer. And here at the center, we consider these precancerous. At this stage, it's what we call in situ. It is confined inside the ducts. It hasn't come out of the ducts, and it hasn't entered the lymph nodes, and hasn't gone elsewhere. That means it's only local, in the breast. Then we have to go through all the various stages, and that will be tough. It's quite serious.
I know all about it.
It's not going to be what like happened to your sister. You've got the image of your sister, but you can't compare it.
I'm sorry.
We are at a very early stage. It's the best we might have hoped for. We need to treat you, and in the end, we hope to cure you of a disease you don't have. Right now, you have abnormalities that show up on an X-ray. You're not ill. You're healthy.
Cancer or pre-cancer? In the confusion, all Monique hears is that she's got cancer.
There is a before and an after the diagnosis. There's a before the diagnosis when you have an ordinary life with your daily routine, and an after when you continue with your daily life with the knowledge that you have a fatal disease. So of course it changes everything. You don't see things the same way. I want to spend all the money I've saved because I'm maybe never going to be able to enjoy it.
The very next day, Monique has an appointment with the surgeon to deal with her precancerous lesions.
So, what bra size are you? 34B? Okay. So what we are going to discuss today is how to treat it. This always involves surgery because it's a disease in your breasts, and we have to remove the abnormalities.
The procedure is automatic. In France, carcinomas in situ are operated on. Despite her distress, Monica is lucky. She will be able to save part of her breast.
The difficulty with your case isn't so much the spread of the calcification. The difficulty is more about trying to find them. They are located in the lower part of your breasts. And if we remove that area there, we quickly touch the curve of your breast, and it's not very elegant, especially when you add radiation as well. As part of managing the disease, if you like, once the treatment is finished, we can correct the other one with a similar operation to even out the two breasts. We could wait a little, but for me, the sooner we are rid of it, the better.
The operation is scheduled for 1 month later. On the other side of the Atlantic, in Toronto, Canada, Patricia is also facing a similar diagnosis.
In life, one has to make choices, and there's two paths. So I chose one path instead of what was a mainstream path, and doctors would say that perhaps there was a dead-end path, but it led me to good things, I think. I've never regretted.
In 2005, after a breast cancer screening mammogram and a biopsy, her surgeon told her that, like Monique, she had precancerous lesions.
He told me that they had found DCIS, that the core samples had showed that I had DCIS, and it had to come out. We have to remove it, he said. I said, well, what is the risk of this becoming actual cancer? And so he said, well, 30%. So I mean, I don't know. I said to him at the time, well, that doesn't sound too bad. And he sort of looked at me, and I said, well, I'd like another opinion. I really strongly felt that I did not want to be turned into a patient. And I kept saying that to myself. I'm not sick. I don't want to be made sick.
Against the advice of several doctors, Patricia refused the operation. This rebellious nurse, who was age 66 at the time, accepted the risk of living with pre-cancerous lesions in her breast. This strength to say no, this freedom of spirit, is the same that pushed her several years previously to take to the sea with her husband on a yacht.
I think that going away cruising separated us from regular life and society and the way people normally live, and I think it made us more independent and gave us the strength to be our own person. When you're out in the ocean, it's all up to you and how you handle everything and how you handle Mother Nature. And as Austin always said, you don't argue with Mother Nature, you just do what you have to do to get through strong winds or a storm or something like that, and there's no one to rescue you.
But Patricia did not simply abandon herself to fate. She surfed the web, read studies, and contacted researchers.
This is a group not exposed to screening. Their early stage is flat. Their late stage is flat.
Forsaken by her doctors, she made up her own mind while fixing some limits.
I guess my approach at that point was that I'm willing to do a watch and wait myself. If I found a lump in my breast, I would definitely go and have it investigated. If it was cancer, yes, I would definitely have treatment then. I do feel that DCIS is not cancer. It's pre-cancer. It's cells that are starting to change. And apparently, from my reading, sometimes this process of these cells changing can stop.
For years, she has lived without any trouble from her carcinoma in situ.
3 years ago, my family doctor convinced me to have another biopsy. So I went and I had the biopsy and the results came back negative. They couldn't find any DCIS.
Her precancerous lesions have disappeared on their own. Is Patricia the exception that confirms the rule? She chose to do nothing, while Monique opted for surgery. So is there any urgency for early diagnosis? And does it have any bearing on mortality rates? All around the world, researchers are trying to answer this question. Epidemiologists have seized upon the problem. These doctors don't see sick people. They just deal with statistics. In 2005, Philippe Autier was convinced of the benefits of screening, and to prove it, he analyzed global cancer records.
Le principe du dépistage des cancers est très simple.
The principle of cancer screening is very simple. You have to try and detect presence of cancer before it becomes advanced. If breast cancer screening is responsible for reduction in death from breast cancer in a population, then we should be able to see a reduction in incidence of advanced breast cancer in that same population. That would be the only proof of the efficiency of cancer screening.
In the case of uterine cancer, the rate of advanced cases of the disease fell significantly when screening began. But when Philippe Autier studied the rate of cases of advanced breast cancer, he saw no reduction, despite the screening program.
And there, to our surprise, we thought that nothing had changed. The incidence of advanced cancer remained stable. Nothing seemed to be able to change it. And that's when we said, Houston, we have a problem. We wondered, what is the point of breast cancer screening and mammograms? What does it actually achieve?
The doctor's initial convictions collapsed in the face of the data. In France, another epidemiologist, Bernard Junot, was also struck by the figures. He counted and recounted the deaths, and his conclusion was irrefutable. Despite screening, mortality rates remain the same. In 1980, 8,500 women died from breast cancer in France. In 2012, 8 years after the screening program was set up, the figure was 11,800, an increase greater than the natural growth of the population. But at the INCA, the French National Cancer Institute, which set up the screening program, Jérôme Viguier dismisses these figures with the wave of a hand.
The mortality rate from breast cancer in our country is decreasing. You can't compare figures without taking changes in the population into account. In France, the population is aging. We're living longer, in good health, so we have more time to fall sick. Women are surviving longer, so we have a growing number of women who might develop breast cancer. So if you look at the past, the absolute figure cannot fall when you have a significant reduction in relative mortality from breast cancer in our country.
De la mortalité par cancer du sein dans notre pays est de façon importante.
To the INCA, there is only one significant statistic. The mortality rate is in decline. Over the past 30 years, the number of breast cancer cases has doubled, while the number of deaths has remained the same. Therefore, more women are being saved, and that is due to screening and an improvement in treatments. But there is another possible explanation, and it requires us to look at cancer from a new angle. From the depths of Vermont in the USA, one man may be turning everything we think we know about the disease on its head.
How you doing? I've always been sensitive to these issues since my father died of cancer at my age, at age 60. Having my wife develop breast cancer was a powerful reminder both of how important treatment is and how women who have clinically detected disease, not detected by screening, can be successfully treated, which is a message I think women everywhere should understand. At the same time, these experiences give me the sense of difficulties of cancer treatment, and that motivates me to make sure we're putting the right people through that process. It's not enough simply to find more early cancer. What you've got to do is you've got to lead to a decrease in the amount of people that present with advanced cancer.
Gilbert Welch is a doctor and professor at the University of Dartmouth. He has studied the same charts as the INCA and Philip Autier. Those that show the cases of cancer are doubling without the number of advanced cancers or deaths from cancer declining. He believes the battle over the figures is in vain and that we are saving women who don't need to be saved.
There is an epidemic of breast cancer, and I think it's secondary to screening. I mean, the truth is that our practices as a medical profession can have tremendous influence on the apparent amount of cancer. So, ironically, looking hard for cancer is a recipe for a cancer epidemic. And it has allowed us to sort of understand that there's a vast reservoir of abnormality in the human population. We all have abnormalities. The breast is a gland, like the thyroid, like the prostate, that is turning over cells a lot. That's what glands do. And so their cellular abnormalities are not rare, they're common. But we don't all develop clinical disease.
Gilbert Welch refers to the Nielsen study. In Copenhagen in the 1980s, pathologist Maya Nielsen had the idea to autopsy the breasts of around 100 women who had not been diagnosed with breast cancer. The only thing they had in common was that they had all died unexpectedly, from criminal or accidental causes. When she examined their cellular breast tissue under the microscope, she found something she was not expecting. In her sample of dead women, the pathologist thought she would discover that 6% of them had breast cancer, believed to be the normal incidence in the population. However, she found the figure was closer to 20%, 3 times what she expected. This would suggest that there are numerous occurrences of what we call cancer that are never diagnosed. Maya Nielsen had just proved the existence of dormant cancers.
If we start looking for early forms of disease, one of the things we need to understand is we're going to be treating people who have these indolent cancers. They meet the pathologic definition of cancer, but they're not going anywhere, and we'll treat them.
Every week, Gilbert Welch warns his students about this screening that mainly reveals dormant cancers. The phenomenon involves precancerous lesions, but also invasive cancers too. He calls this overdiagnosis.
My major interest in cancer screening is to tell people both sides of the story and let them make a choice so they understand the benefits and the harms of the deal.
Usually, at least in my own personal experience, I assume in many others, most people would want to get rid of the problem as quickly as possible.
The question is, if becoming a case becomes evidence of the usefulness of the effort, it's a recipe for more cases. My best estimate is somewhere between 1/3 and 1/2 of mammographically detected cancers, and that includes DCIS, represent overdiagnosis. I know that sounds like a lot, but this is the basic truth about screening. You have to involve literally thousands to help a few. And one of the questions I've been raising is that if you have a situation where you have to involve 1,000 people, potentially to help one, what happens to the other 999? And that's an important thing for healthcare to be aware of. What happens to all the rest of them?
In Paris, after 42 years in practice, radiologist Bernard Duperret has reached the same conclusions. Yet in the 1980s, he was involved in the introduction of the breast cancer screening program in France.
In the early 70s, we thought the development of a tumor was linear, over time, that it was proportional to the passing of time. When it's small, it's early. When it's big, it's advanced. We thought that mammograms allowed us to make a diagnosis before the tumor was palpable. Back then, we thought we'd diagnose all the tumors and then treat them as early as possible. And as a result, we'd solved the problem.
Et par conséquent, on aura réglé le problème. But in practice, he realized that cancers do not all grow in a linear fashion. Some grow very quickly, and others take more time, or even disappear altogether. That throws into question the relevance of early detection. Bernard Duperret now refuses to carry it out. He has closed his independent practice and is now looking into our understanding of cancer.
In the beginning, we might have thought that this overdiagnosis was marginal, but it ended up being huge. Moreover, it begs the question as to why there are some cancers that just keep on getting worse until the person dies, and others that just don't evolve. Today, we don't know how to tell the difference between an overdiagnosed cancer and a progressive cancer. And this raises a question, at which point are we really sick?
The answer given today is to diagnose as early as possible and to treat precancers and cancers, assuming that they will each evolve into a terminal disease. The day of Monique's surgery has arrived.
Monique has a high-grade DCIS. It's considered to be the stage just before invasive cancer. So the screening process has done its job. By revealing these lesions at this stage, they can be operated in good conditions, and the treatments will be extremely effective.
The surgery lasts for 1 hour under general anesthetic. Monique will go home that same evening. The surgeon, Marie-Pierre Chauvet, carries out 250 such operations every year.
We know that we probably overtreat a certain number of patients who have abnormalities that won't grow very much, and which probably wouldn't be responsible for the death of that person. But in general, there are disadvantages to everything we do, and we live in a society where we are never reproached for doing too much, but we are criticized for not doing enough. That's the price of screening, accepting that sometimes we will operate on women who didn't need it.
As a patient, how do we know if we've been saved or operated on for nothing? Marlow is a small town to the west of London. This question haunts Miriam. A professor of philosophy, she has just finished her PhD on rationality and ethics, a subject very close to her heart. 10 years ago, when she underwent her very first screening, they discovered, as with Monique and Patricia, pre-cancerous lesions.
I was completely shocked, because I was healthy, I was well, I was looking forward. I was just starting teacher training. I was at 50. I was looking forward to a new career. My kids were just growing. They were, my youngest son had just started secondary school. Life was fine. And then I was told it might be just coming to an end.
Back then, despite her doubts, after 2 consultations, Miriam followed the course of treatment her doctors advised.
They made it seem like an emergency. I was really put under pressure. They want a result, they want a decision, and they're not gonna, I knew I wasn't gonna get any more of that doctor's time. And you're conscious of other people with life-threatening diagnoses needing his attention. You just think, I can't take any more of his time. So you're put under this pressure. But there's no need. I could have gone away and said, well, I'll think about it, I'll read about it. It's when it's all over, you start to evaluate, you start to assess.
The operation was more complex than planned, and Miriam lost her entire breast.
They actually remove a part of your body. It is an amputation. It is so shocking. It is so shocking. I identified with soldiers coming back from the war, and it wasn't treated like that. It was treated like going to the dentist or something. They just, process you through nothing. You're not supposed to care. And I did care.
Today, she has grave doubts about her own experiences and is trying to raise awareness to help other women.
I may or may not have had my life saved. I may or may not have needed any of the treatment I had. I had no way of knowing, and nobody had thought fit to mention this to me. People seem to think that I'm talking about me here, and I'm saying in my case, it's unlikely that I've benefited, but other women have benefited. No, this is not true. You cannot know. No individual can know. I feel betrayed by those individuals, every single person who spoke to me and failed to tell me what they knew. They betrayed me.
What if breast cancer screening does more harm than good? One man is today convinced of this, having closely analyzed all the data. In 2000, Peter Goethe, the leader of the independent Nordic Cochrane Center, was asked by the Danish government to consider this question.
I was asked by the Danish National Board of Health to review the screening trials. 5 weeks later, there would be votings in the Danish Parliament whether we should have screening in the whole country. And we concluded that we could not exclude the possibility that mammography screening might do more harm than good. This report never made it from the National Board of Health to the Minister of Health. So he didn't know about the report on the day of the votings. So something dirty was going on.
Stung into action, Peter Goethe, a biologist and specialist in internal medicine and statistics, persisted, raising the alarm. His studies were published in 2 prestigious publications, The Lancet and the New England Journal of Medicine. They caused a sensation. The New York Times and Le Monde ran front-page stories. For the first time, someone had examined the harmful effects of overdiagnosis.
Overdiagnosed cancers, they would never have been found without screening. So these women are healthy. And when you treat healthy women with radiotherapy, for example, then you kill some of them because they develop heart disease or lung cancer or other cancers. And these additional deaths in healthy women amount to at least as many deaths as what mammography screening can prevent in terms of breast cancer death. So it's clear to me that there is absolutely no survival benefit by going to screening. Screening is unequivocally harmful. There's no survival benefit. It doesn't exist.
Peter Goethe had reanalyzed the initial studies in detail, the ones carried out during the 1970s, which predicted 30% more deaths from breast cancer amongst women who weren't screened. And according to Goethe, these studies contained irregularities. The first was that certain women were excluded from the group that underwent screening because they had a history of breast cancer. But no such exclusion was made among the group that did not undergo screening. Naturally, this would increase the mortality rate. The second was that the causes of death were sometimes difficult to determine. Among the group that was not screened, deaths where the cause was uncertain were attributed to breast cancer, again increasing the breast cancer mortality rate. And thirdly, in the study that was the most favorable in terms of screening, the man running the trials owned a private company involved in mammograms. And all public breast cancer screening programs were set up because of a belief in those studies.
There are huge financial interests in mammography screening. In the United States, it's a billion-dollar business. And also, in many countries, you have national mammography screening programs organized by the state. And it's always very, very difficult to stop national health programs. Because in order to stop them, you have to admit as a politician, we were wrong. Politicians rarely admit that they did anything wrong.
We contacted the French Ministry of Health, but they couldn't find the time to respond. But what do they think about it at the High Authority of Health, the body charged with evaluating the benefits of public health policy in France?
For the
moment, France's health authorities has a position that for any medical intervention, there are benefits and risks, and those benefits should outweigh the risk. In general, breast cancer screening reduces the mortality rates by around 20%. It's a tricky and emotional subject. I'm not sure that if you asked me again in 5 years' time, I'd say the same thing as I'm saying today.
Especially given that breast cancer screening has yet to be fully understood. In Birmingham, in the UK, one doctor is carrying out some unusual experiments that may revolutionize medical practices. He believes that precancerous lesions, or carcinomas in situ, detected by chance, should not be systematically removed.
Ductal carcinoma in situ is not one disease, it's a spectrum of diseases, and we call them low, intermediate, or high-grade DCIS. And we're interested in finding out whether low or some of the intermediate grade DCIS really need to have surgical treatment or not. And then the patients will be randomized to either have surgery as they would normally, so half of the patients go through the normal treatment pathway, and half of the patients, instead of going immediately to surgery, would be observed with mammograms performed every year for 10 years. But I'd be very surprised to find that there's a survival difference. I think it's a very safe trial for patients to go into, and that what we end up doing is seeing that patients can delay their surgery safely without any detriment to their overall survival.
The first results will be available in 15 years' time. Meanwhile, Ghislaine will continue to enjoy her grandchildren between her screenings. Monique eventually had a second operation on the same breast and 35 radiotherapy sessions. Nobody can say whether or not she was saved by her screening and subsequent operations, but she feels reassured. Miriam will never know if she was the victim of overdiagnosis, but she continues her fight to provide women with better information so they can make informed choices. Patricia is preparing to set sail again on her boat. After scientific studies and biopsies, she is reassured that her precancerous lesions have disappeared. 4 individual stories that reveal the complexity of a breast cancer screening policy that creates more doubt than certitude.